So as we said, we will discuss the anatomy of the posterior segment. So the posterior segment is mainly we are talking about the vitreous and the retina. So let's start first with the vitreous cavity. So what is the anatomy or what are the anatomical details of the vitreous cavity? So as we know, we will start first with the boundaries of everything. So what are the boundaries of the vitreous cavity? The limits of the vitreous anteriorly, it is limited by the lens, the zonule, and the ciliary body, while posteriorly it is bounded by the retina and the optic nerve, forming a total volume of 4.5 millimeters. Can you hear my voice? So those who cannot hear, please restart your browser. Okay, let's continue. So here we are. Here is the vitreous cavity, the vitreous fluid. You have now the lens and the ciliary body and the zonule forming the anterior boundary of the vitreous, while the retina and the optic nerve will form the posterior boundary of the vitreous. The space or the structure that occupies the vitreous space is called the vitreous body, which is a gel-like structure. So what is the vitreous body? The vitreous body is a transparent gel that fills the posterior 4/5 of the globe. So it fills the most of space of the globe formed by the vitreous gel. And what is its shape? It is like a sphere with a saucer-shaped depression anteriorly for the lens, which is called the anterior hyaloid or lenticular fossa. So here it is. The vitreous is forming like a sphere, but in the front surface or the anterior surface, it is depressed, as you can see here. And this depression is called the anterior hyaloid fossa or the lenticular fossa because this depression is occupied by the lens. And it has an anatomical consideration that in the vitreous in this area is condensed. So the vitreous is condensed, forming what's called anterior hyaloid face. And by the way, this anterior hyaloid face is the last part that can be seen with the slit lamp without the use of auxiliary lenses. So if you are not using a specific lens or the fundus lens, you will, and you are using just the slit lamp, this will be the last area that you can be able to see without use of any direct or contact or non-contact lenses. It's called the anterior hyaloid fossa. Just let me switch off the WhatsApp. So again, the vitreous is a sphere with a saucer-shaped depression anteriorly for the lens called the anterior hyaloid or lenticular fossa. And in the region of depression, the vitreous is condensed, forming the anterior hyaloid face. And then we will know that there is certain adhesions between the lens and this anterior vitreous face called capsulohyaloid ligament. Here we come to the most important part in the vitreous, and that's more very frequently asked in the exams that carry anatomical and surgical considerations, which are very important, which is the vitreous attachments. The vitreous attachments are very important to be asked in the exam and very important in the vitreoretinal surgery to be able to know where are the vitreous is attached to the surrounding structures and whether these attachments are strong or moderately strong or weak or loose. So let's start first. Uh, can you hear my voice? So, Dr. Doha, you have weak connection. No, I'm not talking yet. Okay, so back to the vitreous attachments. So we have the cortical vitreous, and by saying the cortical vitreous, we are meaning the peripheral part of the vitreous. So the cortical vitreous is loosely adherent to the internal limiting membrane of the retina. So the internal limiting membrane is the most inner layer of the retina, as we will see in a while. So the cortical vitreous is loosely adherent and loosely attached to it. And this attachment even gets weaker with age. So as we age, this attachment gets weaker, and with vitreous degeneration, this will lead to vitreous liquefaction, causing vitreous detachment and retinal detachment. So let's see what is the importance of this attachment. So the cortical vitreous is the peripheral part of the vitreous, and here we can see this is the vitreous. This is the center of the vitreous, and this is the peripheral or cortical vitreous, and this is the core of vitreous. So with there is the cortical vitreous is loosely adherent to the internal limiting membrane of the retina. So when we age, the vitreous undergoes contraction, and this is because of liquefaction of this vitreous gel. The vitreous undergoes liquefaction by the gel, so this will lead to shrinkage and lead to collapse of the vitreous. This collapse will cause traction over the cortical vitreous over the surface of the retina, which is loosely adherent to it, leading to increased incidence of retinal breaks. So retinal breaks can occur due to posterior vitreous detachment, which is more frequent in the old age due to vitreous liquefaction. And this is because of attachment or adherence between the cortical vitreous to the internal limiting membrane. I hope that this is clear. The next attachment is the vitreous to the lens. So we said that the first one will be the vitreous to the retina, and the second one here we have the vitreous to the lens. We have attachment between the lens and the vitreous, and this is in the area of the lenticular fossa. So in the area of lenticular fossa, that's sometimes called Berger space, which is the space between the posterior surface of the lens and the anterior hyaloid face. This is in this area the vitreous is condensed, forming a ligament called hyalidocapsular ligament or hyaloid capsular ligament. So this is a ligament of attachment which is loosely adherent to the lens. So there will be an attachment between the anterior hyaloid face and the lens capsule, which is called the capsular ligament. Again, this is attachment is loose and become again more loose with the age. So the older we get, the more loose this attachment will be, and this is why Aiki is easy in old age. So does anyone here know what is Aiki? Exactly. It is as Dr. Osama said, it is the intracapsular cataract extraction. So this was the historical procedure done for cataract surgery. It was done by opening a corneal incision and removing the lens with the capsule altogether. So this procedure was easy in the old age because of weakness of this attachment between the lens and the vitreous. However, if it is done in the young age, there will be strong attachment or more strong attachment, leading to higher incidence of vitreous loss. Yes, Dr. Henry, this is not done anymore. As I said, it is historical, so we don't do it because there will be almost a very high incidence of vitreous loss and complicated surgery. So this surgery was previously done in maybe more than 60 or 70-year-old ago, by making a corneal incision and applying a cryoprobe, a cryo application to freezing the lens and to fix the cryo to the lens, and then removing the lens by side to side movement till it emerges from the anterior chamber. So this will depend mainly on its attachment to the vitreous. So if there is a strong attachment, as there is a strong hyaline capsular ligament, this will be higher incidence of vitreous loss. And let me tell you something. This was not only known from a 40 or 50-year-old. This was even known in the era of the ancient Egypt. So the pharaohs have been doing the cataract surgery in their way. So they have known that there is some attachments between the lens to the vitreous, and by weakening of this attachment by old age, this will lead to removing of the cataract. So what happens if one of the pharaohs had cataract? Then they will push him in the head or knock him in the head so that the lens will drop in the vitreous, and that's how they will remove the opacity that will cause obscuration of the central visual axis. So they didn't have lens implant at that time, but they did what they know best, which is just removing of the lens opacity from the visual axis by knocking down the lens into the vitreous and removing the hard cataract or the dense cataract from the visual axis, allowing more chance for some useful vision. It will not be 6/6, but it will be better than nothing. So this again will depend on the presence of the capsulohyalidor ligament or the attachments between the lens and the vitreous. Let's now come to the very strong or the most strong attachment of the vitreous, which is present at the vitreous base. So it is at the vitreous base where is the most important or the most strong vitreous attachment. It's about 4 millimeter of vitreous that overrides both ora serrata and pars plana. So you will see this term override or straddle. Straddle, you will see that in many anatomical textbooks that the vitreous base will straddle the ora serrata and the pars plana. You may wonder what is meaning by straddle. Straddle is like a knight riding a horse. So if a knight riding a horse, he will pass his one of his both legs at one side of the horse, and that's how he straddles his horse. And the same idea works here in the vitreous overlying the ora serrata and the pars plana. So here is the part of the cortical vitreous or the part of the peripheral vitreous. It's about which is called the vitreous base. This is area of about 3 to 4 millimeters, and 2 millimeters of it override the ora serrata, while the other 2 millimeters here overrides the pars plana. So that's how the vitreous base overrides or straddle both pars plana and the ora serrata. So since this is a very strong attachment, or this is the most strong attachment of the vitreous, usually the posterior vitreous detachment will be stopped here. So if the posterior vitreous detachment starts from the posterior retina, it can extend anteriorly till it stops at the area of vitreous base due to very strong attachment between the vitreous base to the underlying ora serrata and the pars plana. The next most strong attachment is at the margins of the optic disc. So this attachment is moderately strong. As you can see here, this is the vitreous gel, and this is the retina, and this is the attachment to the retina. And you can see here that there was attachment to the optic disc head, but it is now separated, and you can see a landmark of this separation present by this ring. So this ring was originally placed over the margins of the optic disc, but is now it is separated. And this ring it's called Weiss ring, and it can be clearly evident while observing the fundus of patients with posterior vitreous detachment as a ring in front of the optic disc. It is just due to separation of the vitreous attachment to the margins of the optic disc. So this attachment is moderately strong. Other weak attachments of the vitreous are around the fovea and around peripheral retinal blood vessels. So these are considered the most weak attachments of the vitreous. So to summarize, what are the vitreous attachments? We have attachments of the cortical vitreous to the internal limiting membrane. And with aging, this attachment may cause retinal detachment, because that there is increasing incidence of vitreous liquefaction and causing more traction over the retina, leading to more incidence of retinal breaks. The second attachment is at the lenticular fossa, which is called the hyaloid capsular ligament of Wigert. And this ligaments become weaker with age. That's why internal or the internal cataract extraction will be easier in the older age due to weakening of this attachment. The most strong attachment will be at area of the ora serrata and the pars plana. It's about 4 millimeters of the vitreous base overriding or straddling the ora serrata and the pars plana. There is a moderately strong attachment at the margins of the optic disc, and when it is detached, it will causing the formation of a Weiss ring. And finally, we have weaker attachment at the margins of the fovea and at the peripheral retinal blood vessels. So these are the gross anatomy of the vitreous. Now let's have just more ideas about the structure of the vitreous. So the vitreous is like a highly diluted solution of salts and protein and hyaluronic acid, meaning that it is the vitreous is about, most of the vitreous is formed of water. So it's about 98 to 99%. And in this water, there is diluted, and it highly diluted contents of salts, water, and hyaluronic acid. And also there are presence of collagen fibrils. This collagen fibrils mainly of type 2. And the viscosity of the vitreous is determined by the concentration of hyaluronic acid. So the more hyaluronate, the more viscous the of the vitreous. So does the vitreous viscosity change over time? The answer is yes, because the vitreous is usually more toward the gel type in young age. So it's more like a jelly-like structure, and 80% gel and 20% liquid, while with aging, the vitreous undergoes liquefaction. So as we get older, the vitreous become more liquid, so it's about 50% liquid. So you can just think of the vitreous like a highly diluted solution. Is about 90 or 98 or 99% of the vitreous is made of water with some salts within it, some hyaluronic acid, and the collagen fibrils of type 2. This water content this water content increase with aging, so it's about 50% with age, while the gel content decrease also with age. So as we are young, the gel is more predominant, while as we get older, the liquid is more predominant. The vitreous is formed of mainly two portions. As we said, the peripheral portion, it's called the cortical portion, which is the outer boundary of the vitreous gel. It is closely adherent to the internal limiting membrane of the retina, and it is loosely adherent to it, as we said. And it is also adherent to the lens at the area of anterior hyaloid fossa. While the central portion, it is less dense than the cortical vitreous. So the central portion is less dense than the cortical vitreous. So both this can be sometimes referred to as a core. So this is the core of the vitreous or the vitreous core, and this is the cortical vitreous or peripheral vitreous.